January 2018 SWOC meeting. I need to talk into the microphone for our YouTubers. So I'm Katie Curtis, and I work over at Evergreen Home Health and Hospice, one of the wound specialists, and I'm going to have you quick go around the room and introduce yourselves. Jane.
I'm Jane Coviello. I'm one of the nurses at the Swedish Cherry Hill Center. I'm Sarah Roxanne. I'm a nurse at Neighbor Care in High Point. We do home care and Mary Wanta at Northwest Hospital Care Tracy Jones, KCI/Sally. I'm Donna, the nurse practitioner.
Wow, what a title.
Sally Munn, physical therapist at Swedish Cherry Hill.
Thank you, everybody. And our next meeting is going to be the second Thursday in February, which is February 8th. And tonight, Sally is going to be talking to us about offloading options. And she is, she said, works at Cherry Hill up in Seattle, Swedish. And at the end of the talk, we've got Dan and Perry from Molnlycke who are going to talk about positioners and about sacral dressings. And there's a study, I believe, you're going to let us know about too. And haven't confirmed with the speaker for next month, but if anybody's got any ideas or anybody they'd like to hear talk or any topics, you know, speak up, let us know. Sally?
Sure. Thank you, Katie.
You're welcome.
Thank you, everyone, for coming on our rainy night here. Deborah has us set up on YouTube, so this is pretty fancy. So we'll see, I have to be a little two-handed. So we're going to talk about maybe, oh, there we go, offloading, and I specifically went for the lower extremity, and trying to give people some ideas, and maybe we can think out of the box. I'm going to share with you a lot of what we do, and I brought some of our very high-tech materials that we use, and talk about how you can do things in different settings, and maybe find some things that you hadn't known to use before. But I want it to be very interactive, so if you have questions or things to add, please feel free to contribute. I will have to Oprah you the microphone so that you can be heard worldwide. So, because I'm a little bit of an education geek, I did put in some objectives just to talk about offloading, and you never know when I can use this again with somebody else. I have the pleasure of teaching at a couple of the PT programs in the area, since I'm the lone physical therapist doing wound care these days. So our local PTs are getting a lot of training in all sorts of wound care. So we've got new grads out there, they've heard me speak. So with offloading, we all know that the total contact casting is thought of as the gold standard for the treatment of diabetic foot ulcers. And I don't know how many people put them on. Do any of us put them on? Kind of, you do. You know, they all should look that beautiful. There's lots of reasons we don't put them on, and here's one of the online slides of putting them on. This is more of a traditional cast in this picture, and if they could all look that beautiful, it would be great. I can tell you that Jane and I, in our 17 years of working together, had put on total contact casts in various ways, shapes, and form. And our poor patients, I'm not sure how they ever walked, because we were of the more plaster is better before the kits were out, and they were pretty darn funny. So as a modality, the physical needs, you have to be able to get the supplies, you have to have the space, the time, and the tools to remove them. And clinically, you need an order from an LIP, expertise, and the staff availability for complications. And in our location in Seattle at Cherry Hill, a lot of our patients just aren't able to cope. They can't plan out how they're going to do it. They can't solve that problem when that cast is on and then they have a problem. Even if we give them instructions as to what to do, either they get it wet and it sits on their foot soggy, or they can see that they're swelling over the top and they're getting a big band of irritated tissue and they don't think to come in. And it just got to be a big problem for us. And so we keep trying them every episode, and we'll try to use them, and then we're unsuccessful and we stop. And we know we should, but we just can never get there. And then we don't have coverage. The beauty of working in a wound center, we don't have coverage on the weekends. So, they wear those casts hopefully on the weekends. And there's nobody there Saturday and Sunday. So for us, it was very difficult to do the casting, and we had to come up with other options. And I don't know if anyone else has the same experience. How do the neighbor care folks do with them?
So I have personally done one. We've done them at the 45th clinic, and I'm in West Seattle. And so I actually haven't managed it, but I know that our procedure is that they'd come in after a couple of days, we'd cut it off, make sure everything was going fine, and then recast for a week at a time until better. And I've heard tale of it working for 1 or 2 patients. So.
I think Deborah said she went through our patients and you thought there were maybe 1.
I'm just wondering if that would work on the diabetic toe wound also, or more the foot wound?
So I think the total contact casting is more designed for the bottom of the foot. That's really the easiest place for it. I'm going to show you how we get our diabetic toes better. And that is a little bit easier than putting on a whole cast. So I went online and found the options for the total contacting kits. This one is the Cutimed offloader kit, and I thought the nicest part of this was it did come with some of the Cutimed sore back, so if you weren't using it in the cast, you had it to use somewhere else. Just the regular online pricing, so I went on and looked on different sites, and it was $129 to $150 for the kit, and then you still had to get a shoe to put on the bottom of it because this kit doesn't come with a shoe on it. So obviously if it's on your formulary, you work with a vendor, it may be more or less. But I thought, well, that sounded kind of like a reasonable price, I guess. Does anybody know how much we get paid to put a cast on? I didn't look. And then there's the Total Contact EZ that comes with the materials as well as the walking boot. And for both of them, there's vendors online support, so there's people that are out there who are educated, much like with KCI, that can tell you how to use the product. The only packaging I could find was to buy 10 casts and 2 boots, and that was about $5,200. Again, this is just right off the internet without talking to a rep. And I thought that's a pretty big investment for something, although you're going to have to do multiple casts on people. So again, they can be a little cumbersome if you don't have the experience, the expertise, the tools. When we were doing them, we didn't have a saw with a vacuum, so we'd have to close the room down because the darn the dust would go everywhere, the plaster dust. So I applaud folks that are able to use them and do well with them, and I'd love to learn the trick. But I don't think we're headed in that direction right now. However, and these are the pictures of the feet that we see after we put them on. The folks who don't come in, they get blisters. I thought something was wrong. It kind of smelled bad. So we don't want to see this in our clinic. So instead, I have put the tools of our trade. There are the things that we use in our clinic. The Med Action Foam felt is this adhesive felt right here. It comes in that beautiful box, and I was going to copy the label, but I can get people information if you want to know who the provider is. There's a big roll of it. It's about $50 a box. And those scissors up top, those garden shears or Fisker scissors, are the best thing in the world to cut this felt. And we used to cut it with bandage scissors, and one of our nurses said, I think we'd do better with garden shears. And someone brought in, or actually it was one of our patients who brought them in. He said, I think you guys need these. And those orange Fisker scissors are the best thing to cut. They got a little stick stiff on us, and we're like, oh, we want to get them sharpened, and somebody said, I know, and they like put WD-40 on them, and they're fine. So those are our big tools for offloading the neuropathic foot. All right, and then everything begins with our assessment of why they are getting the pressure, what's hitting in the wrong place. And if Julia were here, she would talk to us all about pressure. Julia Overstreet, our podiatry friend, would talk all about pressure. But when we're looking at it, and when you have someone, really look at the bottom of their foot, look inside their shoe, and look and see where they're getting the pressure, because it's obvious. It'll be very obvious. And this photo up here, obviously in the middle of the foot, you can see it's protruding a little, and that's where that patient is bearing all the weight. And our job is to redistribute it. It's really not that hard, but how many times someone with a diabetic foot comes in, whether they've been at the podiatrist or somewhere else, and no one's done anything, and you're like, you got to take the pressure off. They can't feel it. They're going to walk through it. So we will treat the wounds. We treat everyone locally. Then we're going to look at the pressure and try to figure out how we're going to take the pressure off, look at the wear pattern, and then we're going to create an insole to redistribute and relieve that pressure. And obviously, again, I'm going to eat the microphone. We look at these feet, and we know that they've got a big problem, and we're going to have to do a lot of offloading to get the pressure off of there. So here are the common sites of irritation with neuropathic changes, and don't you just love those feet? Like, any of us have seen any feet that look like that in our clinic. But those are the common places: the bottoms of the toes, up in the metatarsals and down on the heel. Certainly, I think we're more successful with relieving stuff on the forefoot than the heel. The heel's a little bit more difficult, and we have varying degrees of success on the toes, because certainly the other part to remember is that once you get those wounds on the toes, that circulation may be so poor there's nothing we can do about it. And I think we often forget about that and try to keep changing things, and when really there's not a lot of hope for it to get better. And just a little graphic of what a normal foot looks like and the Charcot foot. And obviously on the Charcot foot, you're going to see where they're going to get that pressure. So if we don't put some pressure relief of some sort in there, that wound's not going to get better. And maybe even if we do, it still won't get better because that foot will continue to collapse. So this is the highly technical felt offloading. And this is not a picture from our clinic, but it's a good picture of about what we do. So in our clinic, we actually trace the foot with the felt, and sorry for folks online watching, we don't have the live video. And we will put it on the bottom of the patient's foot, put the dressing on, and put this on. We might have them stand on it. We might trace it on a piece of paper, put it in a plastic bag, go through a copy machine, whatever. And then we're very wise now after so many years, and we save this bottom piece of paper and write their name on it so that we have it for the next time they come in. I know it sounds simple, right? But it took us a while to do that. And then we'll cut out where the wound is. Now, certainly in PT school and for the orthotists and prosthetists who work in this area, cutting it out like that is not something we're told to do, because you're going to create more pressure around the wound, kind of like making donuts when you sit down for pressure sores on backsides. And originally when we did this, we might only have done just the distal portion of the foot, and one of our orthotists came in and said, you're going to do better if you do the whole foot. And we started doing the whole foot, and it actually redistributed the pressure better and gave us better results. So it's not stiff, but it certainly is somewhat like a total contact cast. Then we'll add in, this one puts the arch on the bottom. We actually usually put our arches on the outside, and we'll build up other things on the outside to get them not to have pressure. This one is one of ours. Like I said, we treat the wound, we trace the foot, and we save that backing as a pattern. We adhere it to the bottom of the foot. We'll put in more felt for more pressure, and that one obviously has a lot. That's an adhesive foam under the wound where the wound's cut out. We'll put more felt for additional pressure relief. And then you have to secure it with additional tape. tape. So we are big users of the cover roll tape, MeFix, whatever the other brands are, because once they start walking, the thing's going to shift. And again, they can't feel their foot, so usually they're pretty tough walking through it. So we'll tape it on very securely underneath, around the side of their foot. We're going to put felt or gauze pads or maybe cast padding between their toes, and then tape it all around their foot so it looks like a little boot that's attached to their foot. And then we'll put as much compression as they need over the top. And if they've got edema, otherwise we're going to put a lot of compression if we've got a wound, as long as they have good circulation. We'll wrap them up to the knee. Usually we'll do at least cast padding and Coban. So they'll go from this, and then we're going to wrap them up into a club, and then put them into, a lot of these folks will still fit into shoes, or a boot, or sometimes a walking boot. So we have, in a sense, created an unremovable surface on the bottom of their foot that they can then walk on. So then they're supposed to keep it dry and clean and come back to us. You know, we love it when they can make it a week, but we've got people who come in probably twice a week is the most we change it. And it is a lot. It's a lot of work, but I don't think it's as much work as a total contact cast. Maybe if, like I said, maybe if we were speedier, it'd be better. Mm-hmm.
So is it literally
We do. Fine.
So you don't moisturize the first person?
There is hardly, they're asking about sticking it to the bottom of the foot. There's hardly ever a problem on the bottom of the foot. I agree with you. We're like, should we do this? And we just started doing it. Yeah, no, you know what? Because then they can take the shoe off, though, and we didn't want them to do that, because then they're not going to wear it. Huh? They don't. Right. One of our last patients today who has wounds on both of his feet, I documented last time in his chart because I was a little irritated by him. Patient admits to walking outside without shoes multiple times during all seasons and weather. And he said it to me that it was kind of like a joke, like, oh, I walked outside to get the mail. And then I was talking to my neighbor, and he said, aren't you cold? And I looked down and I realized I had no shoes on. I was like, so we wrap it on the bottom. And we use barrier. We use 3M no sting Calvalon barrier film to help stick it, just the film to help stick it on to adhere this to the surface and protect the skin. We haven't done that. We have done that. We don't necessarily waterproof them. So we'll wrap them up with the cast padding and the coat band and put a knee high on them, like we would and then treat it like a patient that we've put a compression wrap on. You got to keep it clean and dry. We have cast covers in the clinic.
One of the things that I learned from Julia Overstreet is, and I've used this a couple times in our clinic, with patients particularly who are homeless and they're going to walk outside and it's raining and they're like, oh, I'm going to keep it dry. And I'm like, yeah, right. Take a garbage sack or a trash sack of some sort and have them put it on and then put their shoe over it. And guess what? It keeps them dry. While they're walking out, and, their shoe's going to be wet, but their dressing will be dry.
So we used to do as kids in back east, put the bread bags on your feet and shoe boots. Anybody? All right, so here's a little case study of a patient that we are seeing. The wound has been present, or this is the first time the patient came in, was at the end of October, and the wound had been present for 8 years, and you can obviously see a deformity. She was managed elsewhere without much aggressive offloading, so we treated her with just debridement, moist care, and offloading. And that is the same day picture there, before and after taking off some of that callus. And this is, what, a month and 2 months later. Originally, it's significantly decreased in size and depth. We saw her about 10 times, and that was the beginning of the month, and I think, Oh, I thought I had one more picture of her. Maybe I didn't put it in. But she's continuing to do better. And she said to us, with that foot, with a wound for 8 years, no one has ever done this for me. No one has ever taken the pressure off the bottom of my foot. And she was followed by, I think, multiple different podiatrists. Again, it's not rocket science. We know what we have to do. Take the pressure off and keep it clean, and they seem to get better. So then we were talking about toes, and here's a nice picture of hammer toes and that hypermobile first ray. And remember, specifically as a diabetic foot changes, you get increased mobility in that first ray, and that's why we have a lot of wounds on the bottom of the first toe, and at that met head, because they're hitting and they're weight bearing first on right on the bottom, hitting that MTP joint. And then they get the toe flexion, and they're going to get a wound on the top of the toe, or they might get a wound on the bottom of the hallux because it's coming down too. So you've got to accommodate for that. And commercially, you can get these fabulous crest pads that are available that help lift up so that they're not weight bearing. And this works too for the hammer toes, people who have the callus and the wound on the top. Usually it's the second toe is a good, second and third are usually the best victims for those calluses on the tips of their toes, and you're seeing them for something else and they're like, my foot hurts, and you look and they've got, worn off the skin on the top of their toes. So that helps lift them up. However, again, most of our patients don't have feet that look like that, and how do you find something like that to use? And it costs money, and where am I going to get it? So a little more of our tools of the trade. We add in a little bit of Surgilast in there, and we make our own little crest pads. And we can pass that around. We just take some of the felt, roll it up, put tape around it, and then put it inside the Surgilast, and then apply it however it needs to be applied to their foot. The felt, the tape we put over it seems to be breathable enough, and they don't seem to get macerated underneath it. Now you run into the problem, obviously, if it rubs too much in between. There's always complications if you keep things on too long. But they seem to work pretty well, and we can make them. We can teach people how to make them, and they use them, and they certainly come back with them, and certainly they've not taken them off because they can be pretty grody when they come back to see us. So there I am constructing one of them. We just roll it up, tape it together, and then put it underneath. But this is the greatest invention to mankind for offloading toes. I know, OB tampons. I cannot tell you how successful this has been for our patients. So we joke about it, it says it looks like you have a tampon under your toe, and we're like, it does. It does look like a tampon. People can buy tampons pretty easily in the store. They don't have to futz around with tape and messing around with it. We should try the tampons. So we'd make these up for people, and then we said, go to the store, buy a box of these tampons, and bring it in, and we'll show you how to use it. I think we have maybe 3 people using tampons now, and they're doing great. They're able to keep the pressure off. The tampon obviously absorbs, so when their foot sweats, they have absorption. It's readily available, and they can just throw it out when they're done. I know. Most people seem to use the regular, not the light. I don't think we have anybody using super. But I was looking for a picture online, and I thought, oh, that one will work. So hopefully I put the next, so lo and behold, one of those patients came in today. This was just today, our last minute addition. So she had a wound on the bottom of her first toe. She has a neuropathic foot. We've actually followed that wound on and off for a while. She came in, that little bit of a shadow on her forefoot is a burn from, I can't remember what she did. She burned her foot. And then, of course, she had developed a big callus back over that the wound on the bottom of her first toe. And I said, did you bring a tampon today? And she said, I did. I said, can I take pictures? She was thrilled to take pictures. So this is how she puts it on. She cuts the top and the bottom off, and then that's just a piece of regular tape. And she was very clear that I was to instruct everyone, and the picture on the bottom, the first picture on the bottom, is that she puts the tape on long way first, because if you put it across, it's going to curl and create a tourniquet. Right, which is one of the problems with these. When they get between people's toes, they don't have sensation. If it rubs between the toes, you create more damage. So she said the best way to put it on is to put it the long way first and then secure it the other way. So she puts this on and holds her toe up, and she's wearing some terrible Chuck Taylor type Converse shoes now, which are awful because, of course, her shoes got lost somewhere, or she doesn't have them, or, got left in a car, left on the train. I don't know where they are. And she's maintaining that wound closed, and she has had a wound there on and off, more on than off, before she saw us for a number of years. So she can do this, and she said, do I have to do this forever? Yes, forever. So she's working on getting another pair of shoes, and now we are working very closely with our orthotist to say, I know this is not what you want to do. Most of them want to do cut-outs, not add-ons. I know this isn't how you want this to heal, but this is how we got the patient healed. This is what their shoe has to look like. We can't go with what, this is practically what works. So now we have orthotists building in these little pads in the front of their shoes. Now they got to get in there and be snug, because if they slide too much, you create another problem. But we're having a little bit more success. So you just got the pearl of wisdom for the afternoon, is using the tampons. Questions? Yeah, I should, huh? I bet you. Who makes those? I gotta tell you, it works, right? It works. It works, and there's not much of an excuse, right? I don't know, a couple bucks on sale. I like the OB because they're so small and they don't have an applicator, and I figure I'm already having this guy go buy a box of tampons. I don't need him to look at it and go, what do I do now? Right, so I think the OB work well, and they seem to be the firmest too. A lot of the ones with the applicators are softer, So we've only, when someone was talking about it, we only have used the OB once.
Actually, just thinking out loud, aren't they all the OB ones consented to?
Yeah, I don't think they're scented. There is no scent on them. A lot of them have other chemical things.
So it keeps you having to add issue.
Yeah. And I think they're fairly generic materials. They don't feel like a lot of polyester in there or whatever. All right, and that's what I was talking about, what to do when the wound is healed. We bring the orthotist in and work with them ahead of time to get them some type of footwear as long as they have diabetes and qualify. And it can be a long time. Our patients sometimes come in for a number of weeks where their foot is closed, but they don't have any shoes. And we just figure we have to keep doing that, or else if we take their shoes, if we take the offloading away, they're like, I'm healed, I can go. You're like, no, because if you don't have the shoes, and they have to wear some type of shoe with some type of insole in it every time the foot hits the ground, period. And it's, obviously very, very frustrating, I'm sure, for everyone in this room of you've got to wear those shoes every time. And you can see this one here has a little bit of a built up, one of the insoles. But for the most part, we've really started working with our orthotists to change kind of their approach as to what they're doing for offloading. And I can tell you, as a therapist from the rehab standpoint, doing something like this is totally taboo. That you don't want to add, you're going to add more pressure and somehow they're going to break down more. So it's a hard thing to change for folks. So we do some other really fancy things. And when I'm talking to students or people who are not wound care providers or even the families that we really need to become. You need to teach people to become pressure detectives, because they'll come in. You know, we had someone come in with their mother who's had a stroke and a hip replacement, and she has a wound on her right lateral malleolus, and no one has any idea how it got there. Let me see, what side's her stroke on? The right. And what side did she have her hip replacement on? The right. So, you know, really going over how you get pressure and how you relieve it. So once we know that she's lying with her leg rotated externally and putting pressure on that malleolus, we do things like building up with felt rings around the outside. Again, taboo when you're taught in school because we think we're going to increase the pressure around the wound, but we do it and it gets better. And then we talk to them about positioning, and we'll say, well, look at the way they're in bed, or look at the way they're in the chair, and everyone in the family has to become a pressure detective. And for heel ulcers, I think one of the best methods of getting a heel ulcer better is up on the top in the striped sock, which is putting it on a rolled blanket, right? Lots of people want to put them in boots and do different things, and it seems those boots never come back the right way, right? The foot part's the wrong way, and they've moved the support, and you're like, I don't know how this happened, and they've got funny straps. So we do a lot of education of just keeping the heel off the bed, you know, every time when you go in to see your dad, or when you're in how are you positioned when you're in the dialysis chair for 3 hours? Keep it off and just keep drumming it into people. And then the bottom one is something that we will wrap into people. Another very fancy setup, right, to get heel pressure off when people who have pressure get pressure in supine. Or they're sitting, with their legs crossed maybe, or they, sit resting in the recliner. And this is, 4 ABD pads to tape together. There you go, Deborah. And we build them up on the back of their legs, and then we will wrap that into the compression wrap. So again, they can't be without the pressure relief. Does it look ridiculous? Absolutely. But these are folks who can't take the pressure off themselves. And so we'll build it in and tape it on and then wrap it onto them. And it seems to help. And this is nothing compared to some of the stuff we've done. We'll look at it and need more hands in here. You end up with 6 or 7 pads on people to prevent them from getting pressure on there. So again, this is all very high tech. Hope you're staying with me. Okay. So this is our fellow who is a great case study for relieving pressure and the use of, he is a insole user. So he's a nice gentleman, non-diabetic neuropathy with that hypermobile first ray, and you can see from that 316 picture, he's got a wound there, and he's got darn bony feet. He's over 80, and his feet have no fat left, and he can't feel them. So he came in with this wound, and we got him better. 3 months later, he's better. There's no wound there. He's great. He can afford insoles. He got insoles for his shoes because they weren't covered by Medicare. So he got insoles for his shoes, and life was great until he decided to play golf without his insoles. I didn't know I needed them when I played golf. You said you didn't say anything about golf. Okay, so then we went ahead, got him better again, and the next time he came back, he had taken his shoes off in airport security. He's 80 years old, so we should have been able to keep him on. And we'd said, you can never be without shoes. You got to have the insoles. He was really good about it, wore them. He was back golfing, doing everything, walking the dogs, because his wife's a cripple and can't walk. My wife's a cripple and can't walk the dogs. He's doing everything he wants. From taking them off, putting them on the conveyor belt, walking through, and putting them back on the other way, that wound was back open, right? And so I use it because it is a really good kind of hit in the face of what you really, if you can't feel it, you don't know what happens. And again, he's got no fat on the bottom of his feet. They're really bony. So we haven't seen him for a while. He might not ever want to come back to see us because every time he comes back, he hangs his head. but he is convinced, and I think he's got insoles in his golf shoes, his slippers, his tennis shoes. I'm sure he has a pair of wingtips he still wears. Ooh, see, I'm quick. So I know it's not a diabetic foot, but I thought I'd button it up. I have to give credit to Cindy Farrell, who sent me this picture long ago. And I thought any wound person would appreciate seeing this picture. Isn't that amazing? So questions, comments, ideas on what you do. Get rid of that photo. So I was going to demonstrate on my model. She told me she was going to wash her feet before she came.
But I didn't.
All right, so I'm going to take care of her wound, trace her foot. The hardest part is getting when it's $50 a roll and you feel bad, is getting it the right way. And I'm a little dyslexic, so I always go into the room and I'm like, okay, it's going to be this way, and we still cut them wrong. And it is just a big darn sticker. I'm sticking it on the bottom. If she had a wound, I cut out where her wound is. I think Jane would get wounded right here. And then if she has a wound on her ankle too, you know, she's got that pressure sore because she just broke her hip, poor dear, I might put some felt over there to offload that as well. And then I'm going to give her an arch support. We have not. Plantar fasciitis? I'm having Jane.
So the question is, do we get patients that have plantar fasciitis from compression wraps?
Mainly because they don't have support.
Because they don't have support.
You know, depending on whatever sheet they can get on when they already
Right.
applied or whatever. So I'm wondering.
Have you seen that?
I've had a couple patients that they complain of pain that sounds a lot like plantar fasciitis, and I'm wondering maybe putting the felt in as a arch support might do the trick. I mean, because getting different shoes doesn't make sense for a short-term wrapping.
Yeah. We will add felt even on compression wraps as well if we have to.
You're saying, yeah, patients that we're seeing just for venous wounds and it's uncomfortable, we will play around with felt to make them comfortable. Yeah.
Yeah. All right, and then again, highly technical. So Jane doesn't have bad edema, so she's getting just the cast padding. And if we remember that study that was out a number of years ago when they put the boot on people with the monitor to say how long they actually wore. And no, I would not wrap her pants in at home in the clinic. But if you remember that study, it was a remarkable number. Like people put the boot on with a sensor on, and nobody told them that's really what the sensor was. They're supposed to wear the boot 24/7 until they came back, and they wore it like 17% of the time. Right? And they came in and said, oh, I wore it all the time. Well, we can tell you didn't. So we put her in this way, and this is the same thing. Again, we do it with compression as well. This is how we wrap so if we had the tampon, we put the tampon under there as well, and then we just wrap the cast. This is regular old Coban.
But you can also put the 3M, 2-layer or your 4-layer stretches and all that stuff.
Most of the time, we have a couple patients who don't seem to like the cast padding. I think to us, probably we started with it because it felt softer.
So when you cut extra felt pieces, do you feather the edges?
Sometimes. It just depends, not always. And then she's done. And then she's going to put whatever shoe she has on. You know, hopefully she's not wearing a little boot. But whatever shoe she has on, and most of the time we try to fit people back into their shoes that they wear every day.
Now, before you move, can I just point something out that we also use the felt for? Let's say the patient has a venous insufficiency ulcer right here. It's hard to get the compression. So I'm talking about the ankle right below the malleolus. It's really hard to get tight compression on and not cause a pressure ulcer on the rest of these points. So you can take the felt pad and fill that area and then put the compression over it, and it puts the pressure right on that.
So we'll do something like this. Little kidney bean. Again, it's getting the tape off in front of 10 people.
I have to say, I'm one that kind of bevels the edges on it, and some of the others don't. I don't think it makes, we've done it so much, I don't think it makes a difference at all.
You know,
You
so
might
we
think it does, I don't think it does.
So we might put something like that behind, or we'll put it, move things down along the foot. We'll put additional compression here on the bottom of the foot. In this direction if they need it. And then the other thing that we've done a little bit of is we've actually started using some kinesio tape underneath them as well, which is kind of the PT modality. Kinesio tape, right. So, you know, kinesio tape can go surface to deep, so we'll use a light surface kinesio tape kind of along the lymphedema guidelines of trying to move swelling. So if we have a persistently swollen foot, I might cut the tape in this direction to facilitate flow up the leg. Yeah, like the fingers. And then we've also used it on someone who had, what direction was her foot? She was really inverted. She was really inverted, so we put the tape on the bottom of her foot and brought her foot out this direction with the kinesio tape. It seemed to make a difference. We put that on first. That goes underneath.
And then trying to wrap.
And then wrap. We'll position a little bit more and wrap in that position.
Trying to wrap that.
Can I make a couple comments? So when I was in home health, we didn't have this fancy felt stuff. And a lot of our patients are homebound, bedbound, sorry. So instead, like for instance, if they'd have a wound on their malleolus, we would take ABD pads, cut a hole out, put the ABD pad on that, and then just lightly put some Coban so it stayed in place, or tape or whatever, but that was how we would offload those spots. We would also use the ABD pads. A lot of, I'm sure we've all seen it, the very elderly patients with those really thin spines, and they're kyphotic, and they're hanging over like that, and they get the wounds right along the spine. We would take ABD pads and tape it up and down their back on both sides, and that offloads it while they're laying in bed or sitting. Yeah, like that. So on so putting the ABD pad to the side of the spine on both sides. Yeah. Talking about that one, Deborah, I had an uncle who was 102, and he had what they were sure was a malignant something on his back. And will you come see him? And I said, well, I'll come see him. You know, that's what I do. Oh, no. I said, no, I'll come and see him. So he got a pressure sore from the way he was sitting, because he was sitting in a stiff back chair. And I said, you know, this is what we need to do for wound care. My cousin was taking care of him, and I was trying to figure out how to get the pressure off the back of the chair. She went and bought a thick memory foam bath mat, cut the relief where she saw he was getting the pressure, and lo and behold, his doctor was actually going to biopsy it because he was sure it was something. I was like, he's 102, and he did not die. He died at 102 and a half, but he did not die with a wound on his back. So, I mean, it's really being, you know, think of all anything you can use.
And I put it in the back of the chair, so the cutout was where the pressure was. That worked also.
Yeah, I think just really being creative, and I think our job is to make sure we're teaching other people to be creative, because things that we do all the time, and I'm sure anybody else who works at a wound center, there's all sorts of things you do all the time, and people come in and think you're a miracle worker. It's because it's our experience and what we do, and it's not, you know, we think of it as kind of a common thing, and we should all know how to do this, but to other folks, it is a mystery. So giving ourselves credit for the knowledge that we've acquired and know to put into practice.
Well, I know one thing you shared tonight that I will take back to my facility is we recently had a lady who had she had Harrington bone rods, and she was still going this way. The Harrington bone rod was actually sticking up, and I'm afraid it's going to go through. But she had developed a pressure ulcer. She goes dialysis, so she's laying in the bed a little bit trying to do. And your idea of the ABD pads is wonderful. I'm going to get in touch with home health or wherever when she went home. That's the most wonderful idea for her and so simple.
Yeah. The other place we sometimes pad too is, after your wrapping is along the tibia, we'll put ABD pads, or sometimes there's, packing sponge or something that comes out of some package that we'll save and put on either side, or maybe a piece of facility foam that someone's not using in a wound vac might go to pad the front of a tibia so that they don't get too much pressure, because as we all know, anytime you've heard us talk, we compress everything, so sometimes they get really irritated because their legs are, they're now so skinny. They haven't been that skinny in years.
Do any of you have any tips or pearls that you use in your practice that we haven't discussed tonight that you would like to pass on? Okay, well, there's no other comments. Thank you, Sally, for coming and sharing us some tips and little pearls about how to offload and things we can do for our patients. We now have Perry and Dan from Molnlycke. They're going to come up, and Jane here, our stand-in patient, is trying really hard to cut off the wrap, and it's hard, which is good because we don't want our patients to be able to take these things off. Because when they're wearing these compression wraps and the insoles, custom insoles that we create out of felt, it forces them to wear it 24/7, which is one of the biggest problems, is patient adherence to the plan. Yeah. Oh, yeah. Okay, and here's Perry.
Oh, now we have something new to wrap it into people.
Okay, that's it. That is, yep. Well, thank you for having us.
You guys ready?
Well, thank you for having us. My name is Perry, and this is Dan, and we're with Molnlycke, and we kind of do a couple different things with our roles, and I know some of this might be a little bit of a repeat from a presentation that we had done a few months back. Actually, we're at Northwest Hospital, but with the topic of offloading, I wanted to just kind of go over and or review or show for the first time some of the folks that maybe weren't at the other presentation a couple months back at Northwest Hospital, are fluidized positioners. And Molnlycke, you probably are familiar with and know primarily for the dressings on the wound care prevention and treatment side. About a year and a half ago, or almost 2 years ago now, Molnlycke acquired a company by the name of Sundance, and that's what the little fluidized positioner is that we've got. And the company Sundance had a portfolio of products that kind of rounded out pressure injury prevention for what Molnlycke was looking to do. Part of it included the fluidized positioners. There's an offloading heel boot. We have a sitting device for kind of a sitting cushion, and then a turning and positioning system that you see more so in the hospital setting for acute folks. And what's involved with most of those devices are these little fluidized positioners. And what makes these kind of unique, if you think about what we typically use to kind of reposition and or position our patients, we think about a lot of times it's wedges or towels or pillows or things like that. And I'm thinking a lot of times in the acute setting where patients are immobile, but it's oftentimes in your all setting too, when you're working maybe in an outpatient clinic or sometimes in home health, where you need to be kind of creative and come up with your own thing. So maybe that's where something like this comes into play. These are small. There's about 20 different sizes. The smallest is like 7 inches by 7 inches. And what makes them unique is that you can mold them into any position, in any shape, and it will maintain that shape. And then as we put our fingers in there, it'll do that. So it has what we call zero flow and zero memory. And that makeup of those two things is together what the patented term conformational fluidized positioning is. And so it's typically something that we see with patients that we need to either position them in a certain format, or if we're looking to offload the patients. Now, for patients that are ambulatory and moving around, it's kind of a different story on maybe an application you might come up with, if there is an application for it. But having said that, I know, Deborah, you mentioned an instance where you had a patient that came in that utilized it maybe as, kind of in conjunction with their, to put it in their pants for sitting. So that was kind of a unique one. Oftentimes, to that point, it's the caregivers that oftentimes kind of give us the best practices where they see these. So anyway, just wanted to point this out as to kind of what it's utilized for and maybe how it can kind of come into play for your all settings. Typically, in the inpatient side, we'll see it. There's a larger one that I have over here that we might use underneath the head to position the patient and or to offload the occiput for patients that are immobile, or maybe they've got a pressure ulcer or pressure injury we're trying to take pressure away from on the occiput or mold it away from the ears. A lot of times it's a larger one that maybe goes from their hip up to their shoulder. If patients are in a sideline position, or you just want to position them and hold them in that position while it's at the same time kind of offloading. The smaller one here like this is integrated within our offloading heel boot. And then these are also utilized in the NICU and also pediatrics for developmental positioning as well as for offloading. So there's really not a one-size-fits-all for everybody, I guess would be the message. But they can do a lot of different things based on what the application or need might be. So they are, yeah, they're single patient use, and it's recommended to have typically a barrier between this and the patient's skin. So depending on the size of them, some of them come with covers, or you could just use a sheet or a pillowcase or something like that with it as well. But they can be wiped down just with any hospital approved disinfectant and reused for the same patient. But over time, that material that's the makeup inside will begin to break down, and so it won't maintain or hold its position quite as well. So it begins to break down. For that reason is in part also why they want to have them for single patient use.
How long do they last?
Yeah, so it kind of depends. I've got some samples that I've been carrying with me for 3 to 6 months in the car for demos and things of that nature. And depending on the temperature in different climates, sometimes that'll cause them to break down, get a little bit soupy on the edges. They're warranted for 90 days, and that's from the time of onset of use. And there is a date that's typically indicated on there as well. But we would honor it up, from the start date of patient use there. So, anyway, any other questions?
Now, did you say you have a heel boot that has this, or you just put this in the heel?
Yeah, we have a heel boot that's integrated within the boot. I didn't bring it, but if anybody would want any information, with those little flyers I passed around, there's my contact along with my phone number, and you're welcome to email, and I can get you some more information on that. Typically, those would be for the non-ambulatory patients, so it's not a walking cast or anything like that. It's just one to help offload that heel, and this is integrated right in the Achilles area, is where that sits to kind of offload that vulnerable Achilles area there. Well, thank you, everybody. I'll turn this over to Dan, and Dan's got a couple things he'll touch on too.
Thanks, Perry. I'm Dan Henkin. I'm the territory manager for Seattle East. And we do have Sandy in the back, too, who many of you know. She covers Seattle West, covers a lot of Seattle, Seattle North, and the East Side as well. I want to talk to you a little bit about a couple items that are newer for us as far as new designs. I put together little packets for you if you want to open up those little packets. I think most everyone has a packet, a little green packet. I was going to talk to you about a couple of products that we've redesigned for better patient use. I loved Sally's presentation because definitely a MacGyver, because I know a lot of you in wound care are like MacGyver and do a lot of creative things to help pressure injuries as well as treat wounds. But I want to talk to you a little bit about some of the redesigned products that we have. You're familiar with our Mepilex Border Sacrum. We actually have redesigned our Mepilex Border Sacrum to make it more user-friendly, not only for the staff members, but also for patients as well. We've added little handling tabs, so it's easier for skin assessment. We've also added a little wing at the bottom, too, so we're able to create a little better seal at the gluteal cleft. And we've also actually made it a little bit wider as well, so you're getting some better sacral coverage as well. There is a sample of the sacrum dressing in your little packet. I have a small sample in there. If you want a bigger sample, I have some of those as well. I just can't really fit them in a packet that easily, so, but I could definitely get you a larger sample as well. It comes in the two sizes, the smaller size and then the standard size, which is, yeah, exactly. It's a, the exact size on it, Sandy, is 8.7 by 9.1 on the new one for the larger size. Yeah, exactly. And then the old one was 9.2, I know. So it's a little bit different on the way it's designed because it's obviously a little bit wider than the other one because the other one was more of a heart shape. I've also included in that packet for you the heel, the brand new heel dressing as well. This actually is 40% bigger than our previous heel dressing. So it's great because you're going to have malleolus coverage compared to our previous dressing where you did not have that. You can see I actually have my little foot sample there as well. You can pass that around if you want, but you can see how much coverage it has. It is 40% bigger, like I said, than the previous dressing, so it's going to be a lot better for preventing pressure ulcers. The last thing I want to touch on quickly is a study that was recently done, which you may or may not have heard of or have seen. Have you all seen the Padula study? Anyone? Yeah, I'm sure Sally's shaking her head, yes. So the Padula study is an observational cohort study that was done recently. It was actually just in a recent September-October edition of JWOCN. It was actually a 6-year observational cohort study done by Dr. William Padula. It was done 38 academical medical centers in over 1 million patients. What they were able to find when using Mepilex Border Sacrum specifically is they were able to reduce 1 pressure injury per quarter per facility. They were actually able to reduce treatment costs too. Before they started using Mepilex Border Sacrum, the cost was $120. It went down to $43 per patient. So a $77 cost savings per patient is what this actual study showed. There is actually a little summary in there, which I think is great. It's a little fold-out piece that shows some of the benefits of why this study is important and why it's important to you. Does anybody have any questions on the Padula study? We think it's really probably the best study out there because it's more of a real-world, real-life study because it was an observational cohort study done over 6 years. And with that many patients as well, really Dr. Padula just wanted to see, does the sacrum dressing really work? We've had other studies that have shown and proven that we've gotten great results, but it actually, we are seeing great results by this particular study. No questions on that? No? Well, great. Thank you for your time. Appreciate it.
dressing. So I just wanted to show how you would actually inspect it. So I know this group got to see when it's on. So you're just going to take the top layer off, and you can just, without actually removing the dressing, just look at the heel, and then you can put it right back down again. So we've actually improved the tape on it too. So it's going to stay in place, less rolling. And I was admiring Sally, how quickly she wraps, and what a perfect job she does. So.
Fine, thank you.
So you do that.
If there's not a wound, what's the reimbursement?
Well, it's hard for outpatient though.
Okay.
So, because I know you won't get probably reimbursed for prevention though. But in the hospital, yeah.
Well, did you do safe tap?
Yes, that's how dressing.
I hadn't been doing direct wound care until just recently again, and I used to work with negative pressure wound therapy, and somebody had a new negative pressure wound therapy came in and said, come in and help us with it. And we had safe tack. I'm going, this is the most wonderful thing I've ever seen. For a negative pressure wound dressing. I thought, this is super.
Actually, I wanted to mention one last thing now that you bring up SafeTac too. Is there's actually a piece I put in that little packet. It's the middle piece that says 5 layers, 1 truth, because we actually do have 5-layer design that is different than competitive products. So there's actually information in your packets that go step by step. I won't go over that right now, but there's step by step what our different layers do for you. I don't have enough time to go in depth because I can go in depth for a long time to talk about that. But there's actually a website down at the bottom too. You'll see it's molnlycke.com US, and it's at see the proof. C-the-proof. Yeah, I know, right? See the proof. Right. It's actually a really great website because it has all of our clinical information there. So you can go to that site and get all your clinical data through that. Thank you.
All right, and just a reminder, next month, SWOC will be on February 8th, which is a Thursday, and we'll be here again. So, all right, thank you.